Good morning again if you're just joining us. Today is the July 27th Zero Suicide Learning Collaborative. If you could please put your name and your organization into the chat, that's how we keep attendance at these learning collaboratives. Anticipating a bit of a smaller crew today with the change date, so thank you so much for being here. And then if you're from a large system, if you could also put your facility or where you spend most of your time, that would be great. And asking folks, what's something nobody would guess about you after first meeting you? If you feel so inclined to put your answer in the chat. Alice, I'm gonna need to hear a little bit more about saying Lil Jon in 3 different countries.
So I've seen him in the US, Canada, and Mexico, and they've all been completely random each time I see him. He just happens to be performing wherever I'm at the time.
I love that. I think I have the same situation with DJ Khaled. I've seen him 3 times completely unintentionally.
There you go. And it's that type of musician that you see randomly.
Ooh, Robin from Summit Stone can juggle. I'd love to see a Zoom demonstration. I think I used to be able to juggle. I don't know if I still can. We're gonna give folks a couple more minutes to trickle in here. Again, if you could please put your name, your organization, and your facility name into the chat, that would be great. Today, we're going to hear from Lara Dykes from the Colorado Coalition for the Homeless about their zero suicide implementation experience. Super excited to hear about some tools that they've used through zero suicide to assist with that. And then immediately after the learning collaborative, I'll be hanging around in this same Zoom room for our office hours, just in case you have any questions or things you'd want to chat about with me in that space. I am going to turn it over now. Please feel free to continue putting your name, your organization, and I'm really loving the answers to this question about things no one would guess about you in the chat, if you feel so inclined as we get going. But otherwise, I will stop sharing my screen and turn it over to you.
Thanks, Conlon. Let me try to screen share here. Okay. Whoops. There we go. So we are trainers on my team here at CCH, and so we've been fiddling with more inclusiveness related to training and PowerPoint training. So we've added these transcripts to the bottom of the screen. Hopefully that doesn't really bother anyone because I can't figure out how to turn it off. Anyway, so I'm Lara Dykes. Jambo Habari Zaleo. That's hello, how are you in Swahili, which is basically all I remember of Swahili from college, which was a long time ago. So thank you, Colin, for asking me to present. I just want to basically do something a little bit different today than maybe we've done in other monthly presentations. And this is really about some kind of a small specific piece related to our implementation. And so we're going to get into that. And I'm going to show you some specific results from some things that we've been doing on our team. So if you have questions, please put them into the chat and we'll go through those at the end. So I'm going to try to start this training. Oh, it's skipping a slide. So hang on. There we go. So I'm going to start and end the training the way I start and end every single zero suicide training that I do in our organization. And that is to have a slide at the beginning that is a everyone arrive here slide, because these are difficult topics. So if everyone just take a deep breath, stretch, do whatever it is that you need to do to be in this moment. And if while we are talking about things, the moment is too much, feel free to do what you need to do to take care of yourself. Okay, so what is Colorado Coalition for Homeless? If you are not familiar, we are a very large homeless service organization in Denver. We do have one piece of our arm of our organization is in down in Fort Lyon, way down in southern Colorado, but most of our services are in the metro Denver area. It's a 38-year-old organization with about 800 employees. We serve about 4,000 households in over 20 different buildings every night. We serve about 15,000 clients and patients every year with health services. So one of the most important things to note about CCH is that we are unique in that we are a combined federally qualified health center organization, and we are a homeless services organization. There's not a lot of other organizations out there like us, and there's a few across the country, but it creates advantages and disadvantages sometimes, but we are a combined organization. And we are governed by executive team and our board of directors. And something that is also fairly unique to us is a consumer advisory board. Consumer advisory board is something that is a requirement of federally qualified health centers that receive healthcare for the homeless funding. And our consumer advisory board is made up of people who utilize or actively utilize or have utilized our services as provided by CCH in the past. Most of our folks on the consumer advisory board are active clients, and they run parallel to the BOD, to the board of directors in terms of decision-making related to the organization. And many of the CAB members also serve on the board of directors. And we have been lucky enough to also have several of the CAB members be available to us for consultation in our Zero Suicide implementation team. And we have one member of the CAB and of the board who is regularly on the Zero Suicide implementation team. So that helps us stay in tune with what people want and really kind of works towards that power sharing mantra that I think we were talking about either last month or the month before. In this meeting, we were talking about power sharing, and that got me thinking about how we run our Zero Suicide implementation team and what that means for us. I do think we still have some ways to go in terms of the power sharing and the power building. One of the cons that we have run into with the Zero Suicide implementation team has been true power building, in that we have a team built of staff volunteers, solely volunteers. They all have their regular jobs at CCH. So sometimes we don't always have the bandwidth, the power, or the support to implement all the things that we want to do related to Zero Suicide. I also want to mention that our implementation team is also very heavily weighted in behavioral health staff. And sorry about that. I thought I'd muted my Teams chat, but apparently not. We have many behavioral health staff on our Zero Suicide implementation team, which is all well and good, but it also means we are continue to put Zero Suicide and risk assessment and suicide interventions onto behavioral health staff to keep figuring out, which is something that we are trying to climb our way out of. But I can talk about that a little bit more later. We also have experienced a lot of turnover like everybody else, and this has affected our Zero Suicide implementation team quite a bit. So I'm just going to give you a brief timeline here of our implementation. The picture on the left is two of our implementation team members, actually our two HR implementation team members. So we're excited to have HR on the team with us, and they are holding up our badge card. We have a badge that has our risk ID question on it and a flyer that we give to everyone at orientation. When I did a presentation to the board not too long ago, we had pictures of the implementation team members for that. So I snuck a few of them in here. So we were awarded a grant from CDPHE at the end of 2018. We attended the Zero Suicide Academy in the spring of 2019. If anyone remembers the days back when people jammed into a room and did things face to face, I think that might have been the last face to face Zero Suicide Academy. We conducted the self-survey, the organizational self-survey. I'm going to talk about that in a little bit. Right before that academy, we sent out a bunch of organizational communications. And that summer, I think we had our first implementation team meeting. We began meeting monthly. At the end of 2019, we'd selected, kind of tried to work through our process of how we wanted to do trainings, risk assessment, selected the Columbia and the Stanley Brown safety plan as our screening, our risk assessment, and our safety plan. And we had this risk ID question. And then in 2020, we built the risk assessment in the EHR. We trained all of our behavioral health case managers, peers, coordinator staff, which we call supportive services staff. And then in August 2020, we did our first workforce survey. I'm going to talk about the workforce survey a lot, and I'm going to show you our workforce survey here in a little bit. We did our first one that summer. So the timing of when we did this workforce survey is one of the things I'm going to talk about with you in a little bit. So 2021, we continued training our BH and supportive service staff and nurses. And then we did our second workforce survey about a year ago. And then we continued doing training. We are working on our kind of non-direct service, non-EHR documenting staff to train them in QPR. We're working on that now. And then we will be starting our third workforce survey on Monday. We've been doing it basically in August every year. So one of the things that I'm really here to talk to you about today is how our implementation has kind of gone related to some of the specifics related to basically kind of the grant we have and some of the requirements from Zero Suicide and CDPHE for annual reporting. And what would I have done differently? What do I know now that I might have done differently at the beginning if I understood things a little bit better? And I'm hoping that this will benefit some of you that are in early days. If I can give you any wisdom to think through some of the things that I'm going to be talking about, especially related to the workforce survey. And it would be great to have discussion too about other folks that have been doing this for a long time, if they have run into some of the same issues that we have. So one of the major things I would have done is really emphasize the Zero Suicide website and its resources a lot more. I would have probably reread through my statement of work many more times than I have, and paid attention more closely to the organizational survey and the work plan. Hold on. All right, so I think Colin's going to put in the website there in the chat if you want to look at that while I'm talking, because the Zero Suicide website, the resource page especially, has just innumerable resources for you to use there if you are in the middle, if you are trying to set up an implementation especially. It has the organizational self-study, which is usually, I believe, required for the academy. There's a work plan template, which can help you kind of organize the work. I just took a look at that again recently when I was preparing for this talk, and I really said, oh my gosh, I wish I had looked at this before we started our implementation. There's a data elements worksheet, which is also incredibly helpful for setting up what you need reporting wise related to doing your reports to CDPHE and tracking how your implementation is going. And then, of course, there's the workforce survey, which I am going to talk about here in just a little bit. So I would most definitely have taken quite a bit more time to go through all of those elements and seen how they could have helped our implementation team make possibly our implementation a little bit more smooth. So I'm going to talk mostly today about the workforce survey, not only because it's on my mind, because we're doing our third one starting Monday. I also feel like there's really a lot of things that you can learn from it. And it's something that you have prepared to do if you do have the grant. It is not quite so simple as just give the staff the survey, get the results, and turn it into CDPHE. That's not really how I've found. That doesn't work that well, and you can learn quite a bit from it if you are really looking at what the survey contains. So Colin, you can look at it on the resource side, or Colin can also put that website in the chat, and you can look at the workforce survey questions while I'm talking about this. So one of the things that the survey does is that Zero Suicide designed it. They did the heavy lifting for all of us. They designed it. It's Likert scale to get the results that you need to figure out this kind of that aim that Zero Suicide is going for, is that designing a competent and confident and well-trained workforce. That's what the survey is about, is trying to see how that's going. It's literally kind of a report card for how your implementation is going, which is sometimes good, sometimes doesn't feel very good, to get judged on how well your work is going. It's a tool to assess staff's self-perception, their knowledge and their comfort, what they think Zero Suicide means, and how they're interacting with their clients, and how they feel about the tools and the training that they have. And it can really, really assist your implementation team in designing and prioritizing how you do things, how you do your training needs. So you remember I said at the beginning that we're on our third annual one. So we did our first one about a year after we were in our implementation. And it wasn't until really our second one that I realized we probably should have done our first survey at the very beginning, before we really started with and got into the weeds on our implementation. It would have been helpful to start knowing what our absolute baseline was. So we started after a year, and then another year, and now we're on our third year, which is technically kind of our fourth year of doing Zero Suicide. And that makes a difference in terms of not only is our baseline maybe slightly skewed, but we may have done a few things different, judging by the survey results we got in the first and second years. So that is really mainly what I'm here to talk to you about today. So I just quickly put in some slides here. I'm not gonna, this is not, you don't need to look at all this, and you can look at this on the resource page. I just quickly wanted to go through the sections before I go to our workforce survey results. So section 1 is just a general area, it defines staff roles and their workplace environment. Section 2 is about suicide prevention in that person's work environment. They use a Likert scale for many of the questions that you disagree or agree with things. And I just picked a couple of questions in each area to kind of highlight what kind of things they are looking at here. So in section 2, one of the questions is, I am familiar with the Zero Suicide framework, and then they disagree or agree with that. So you can see how it's a direct report card of how well your communication of your Zero Suicide implementation team is doing. So it does hurt a little bit if you think you're communicating and then it comes back with results of like, people don't know what Zero Suicide is. And so that is where you have to kind of move your implementation team to kind of working on some of these things. So section 3 is about recognizing risk for suicide and the staff person's knowledge and comfort. Things like, I know what organizational procedures to follow when I suspect that an individual may be at elevated risk for suicide. Again, these are just examples. There's many more questions in each of these sections. Section 4 is about screening and assessing. Disagree or agree with, I have the knowledge and skills needed to screen. I am confident in my ability. So these questions directly speak to those Zero Suicide principles, and getting the responses back is really interesting for the Zero Suicide implementation team to read through these results. Section 5 is training on screening and assessment. Have you been trained? What tools do you use? That sort of thing. Section 6 is about providing care. It's again really about getting at, what do staff know? What do they understand? What do they feel confident in? What do they need more of? And section 7 is about use of evidence-based practices. And again, I'm confident in my ability to provide treatment to individuals with suicidal thoughts and behaviors. Oh, by the way, there's a lot of branching that happens in this survey also, that the Zero Suicide organization also designs that for you. So I'm going to talk about that later too. Some of the branching for us has kind of gone off at times. And so I'll talk about that a little bit later too. Section 8 is on care transitions. I am familiar with organizational procedures for ensuring that individual's health info is shared during transitions, that sort of thing. And then section 9 is a long list of training and resource lists, and the people select from this list here, which is something that again is provided as part of the survey from the Zero Suicide organization. And it's something that we have toyed around and I'm thinking about doing this year is adding a few of our own specific elements to this list so we can get specific answers to this. These resources are great, but sometimes when people say, yes, I want more of that, we don't know exactly what that means sometimes in terms of specifically work at Colorado Coalition for the Homeless and what that might mean. So that is something we're looking at doing this year. So with that, I'm going to hope that this works here, and I'm going to go to our survey results. Yeah, look at that. Colin, you can see the survey results?
Yeah, looks great.
Okay. So this is our actual survey results from last year that I'm going to go through with you for maybe the next 10 to 15 minutes. I'm not, go through every single piece of it. I just want to kind of highlight a few elements that maybe we struggled with and or we had interesting information, that sort of thing. I'm going to reduce this a tiny bit so we can see more of the page. Hopefully it's still readable to everybody. So we have, this is internal to CCH. One of the first things to think about when you are doing this is part of the Zero Suicide design of the survey, is this respondent position their role. These are defined, these roles come in the survey from Zero Suicide. And one of the things for us in our organization is that those roles didn't exactly coincide with our roles, our job titles, and how things work at CCH. So one of the things that we had to do, it was this piece at the bottom, is that to really look at the results, we had to collapse some of these roles further instead of trying to analyze these one by one. So we put behavioral health and supportive services as one group, which means the case management and behavioral health clinician and support and outreach and crisis services. Those are all different roles here. We grouped those together into one group for us to analyze the survey because that is how we trained them. When we did this the first year and tried to just use these roles and kind of analyze it, we were scratching our heads going, none of this makes any sense. And then we realized not only are these self-picks, so sometimes staff pick a role that we would not pick for them, that happens every once in a while, but we realized that just trying to do an analysis related to how the roles were as they designed by Zero Suicide didn't really kind of help us. And you'll see, I also want to point out one thing here that's something for organizations to think about is about management. So management, you can see, is one of our highest groupings, and this is the people who responded to the survey, right? So we have about, at the time we did this, we probably had 750 staff, and you may have seen it was 184 staff responded. One of the highest numbers is case management and then management. Many of our managers are behavioral health staff. They are behavioral health clinicians. So that's something kind of important to keep in mind when you're looking at our results and when you're thinking about your own results. If you work at, a mental health center or any sort of place where there's a lot of behavioral health going, my guess is that you too would have a lot of people that are licensed behavioral health clinicians in management roles. Then they come in, they answer the survey. First of all, they're more inclined to answer the survey as a behavioral health clinician in the first place, than as a manager. So it's one of our highest respondent rates, but it skews the results when we think about it as just a management role. So hopefully I'm making sense to everyone. Depending on how you know your workforce, it is designed. This is something maybe to think about whether or not you're going to be doing your own grouping so that you can analyze your results a little more easily. So one of the other areas that I want to highlight is something that you probably really want to look at ahead of time is this respondents who experienced a client or patient death by suicide. Also, by the way, kind of quick sidebar. I had a very long and interesting conversation with someone about use of the word individual versus client patient. When you look at the survey that, if you're looking at it on the Zero Suicide resource page, it says the word individual. We changed it to client patient. And then we realized to make it more understandable for our staff that we're talking about our services to other people. And then we had a very long debate just the other day with the evaluation team about, maybe Zero Suicide uses the word individual because they want a more global look, because someone could be working here and experience the death by suicide of an individual that is a neighbor or someone they work with, more importantly. And so, but we changed it to client patient death. And so we are going to continue it that way. And we're going to have to talk about it much more in depth on the implementation team about, well, shoot, maybe should we go back to the use of the word individual? Are we missing something here? So I would love to hear other people's opinions about that. But the thing I want to point out specifically about this question is in last year's and the year before that survey, there was not a time frame attached to this question. So when you get the results, you don't know if in fact, we're seeing that, as we say, 18 people said they had one client, they experienced a client patient death by suicide, and 16 people said more than once. We realized after we got all the results back that we had no idea in what time frame they were speaking of. This is definitely not in that last year, because we did not have that many deaths by suicide. We've never had that many deaths by suicide in our organization. So this is someone's experience ever in their work life. And I believe now in this year's survey, they actually changed this question and added a question that says within the last 6 months, which I don't know if the Zero Suicide organization got feedback specifically about that question, but they changed it to add a time frame. So just wanted you all to know that and kind of think through what that means for you. So one of the things to look at here in this is feeling support after a client death by suicide. This is where you can see this is how we grouped things, that grouping I was talking about, to do an analysis of this. So this is again kind of a report card in my mind for management. If one of your staff did experience the death of someone they know by suicide, and the score here is not very high, we have a lot of work to do as an organization to make sure that staff experiencing that kind of trauma, that kind of loss, that they feel more supported. This is actually, unfortunately, for CCH, one of our lower scoring items, which is kind of heartbreaking, in a way. You can see the 2020 score to the 2021 score, not much movement. In fact, a tick down, which is not the direction we want to be going in. So we are going to be looking at this one very closely this year. And also it's really important for us for that time frame, for that 6 month time figure. Are we talking about this year, this 6 months, or are we talking about 10 years ago? Is the report card of the management right now, or is it a report card of your management 10 years ago? We really need to know that so we can figure out how to help. If it is about right now, then the Zero Suicide team may need to make some quick changes, not so much about what we're doing all the time with clients, which is where our focus is 99% of the time, but perhaps we need to help our managers understand how to support their staff better. So we are really curious about what this response is going to be about. There is a section on leadership, and then we have, this is the attitude towards zero suicide leadership, policies and resources. Again, it went a tick down. We're not exactly sure why, so we are really interested in seeing where this is this year. Last year was, kind of a rough year with COVID and all that stuff. So we are really interested in seeing what happens with that. And then the question is this one in particularly, this is their attitude towards the Zero Suicide Initiative. That's the question. Is this a report card for the Zero Suicide implementation team? Is this a direct, like, how is that implementation team doing? I don't know. I'd be interested to hear how other people feel about that, but I can tell you when we read the results to the Zero Suicide implementation team and they saw it go down, they were kind of like, uh-oh, what do we need to do? What do we need to do? So we worked a lot on our communication this year, organization-wide, directly because of this particular score right here. A couple more things I want to highlight. Let's see. Respondents who received training about warning signs for suicide risk. I wanted to highlight this one because it very clearly shows our problem area, which is medical. So you can see behavioral health and supportive services and even management, here's behavioral health and supportive services. And this is received training at CCH, received training elsewhere. So BH and supportive services is quite high. Management is, fairly high because we have all those behavioral health staff there. Medical is, as you can see, problematic. So we took a look at the survey last year, and that is when we really honed in on trying to get medical staff to participate in the implementation team, because prior we did not have anyone from the medical team on the implementation team. We tried to get, and this is where we started training nurses. So we are hoping that this will result in better kind of results this summer. But we shall see, because we do still struggle with medical staff participating in the implementation team and taking training as needed. A couple more areas, I think, to talk through. Yep, hang on there. I'm going to flash forward a few. Knowledgeable and comfortable conducting suicide risk assessments. Which is, quite an interesting graph. And to me, it's kind of a bit of a report card specifically to the training that we do related to the zero suicide training, which you're looking at the person who does a ton of that training. So it's kind of a report card on how well people are feeling knowledgeable and comfortable after they have received the training. So it's a fairly decent score, but again, room to grow for sure in medical. And then we have trainings received on risk assessments and screening. Again, our highest amount by far is in behavioral health and supportive services, a little bit in management, and then medical is way down there, and we still have quite a bit of work to do related to medical staff training. So another issue to kind of consider and really think about is the training received on conducting risk screenings assessments. That question that comes on the Zero Suicide Survey, workforce survey. One of the things that I find fascinating here, again, because I do a lot of this training myself, is that I do a zero suicide training, and it combines basics on what zero suicide is, and then is the Columbia, the CSSRS training, and then the Stanley and Brown safety plan training. And you can see a lot of people say in service at CCH as their training rather than the CSSRS. So clearly I need to communicate much more clearly in the training that this is the CSSRS training, what you're getting right now, And I also need to just improve the training and make sure that people understand what they exactly are getting trained on. I think I'm training them on the Columbia, but maybe not everybody really gets that, really understands that. Respondents who used a standardized tool assessment or rubric. Again, I just want to highlight our particular implementation issues in medical, and that we have this high use of the standardized tool, the Columbia, and sometimes the PHQ-9 as a risk ID question. And we have high fidelity with that, with behavioral health and supportive services, and very low fidelity with it in medical, which is so really where we really need to go on the implementation team, is really trying to figure out what we are doing related to the medical team. This is rankings of the standardized tools. And then I'm going to skip to really close to the end here on the resources question. Hang on with me.
Unity connection messaging system. Enter your ID.
So this is that last question that is solely about the desire for more training, resources, and support. Let me make that a little bit bigger. Okay, so we have our 2021 to 2020, 2021 scaling here. And this is just always just fascinating to me, in that a couple of areas that are fascinating. One, I don't know about your organizations, but people don't really beg for policies and procedures, but apparently they really want policies and procedures on this at CCH. So this is one thing, and they've said it now 2 years in a row. And it is one thing. Remember that our zero suicide implementation team is made up of volunteers and a lot of behavioral health staff, and not necessarily a lot of that power to make a policy and to make a policy stick, to make everyone follow the policy. So we have kind of shied away from making very specific policies related to exactly what you do, related to zero suicide. But clearly staff are begging for more organizations. Look at this, procedures for communicating about potentially what staff really want are procedural things, what to do in the organization, and what to do in terms of managing people, what to do really about determining what to do next, creating a safe physical environment, as scored high a couple of years in a row, identifying warning signs, which we do a training on that. So we may need to look at that training. And it is a training in Relias, which I'm sure many of you also have Relias. And maybe we need to take a look at that training and go, maybe this training doesn't go into the warning signs as much as we think it does. And then we have another high score on staff roles and responsibilities. So we get a little stuck in our zero suicide implementation team between what all of us want to work on is that direct application of the work that happens with the client. Remember, most of us are behavioral health staff, including me. I'm a clinical social worker. And so we focus on what's going to happen with the client. And what we keep seeing from the staff is they want to figure out what they're supposed to do exactly at their job. And so we need to maybe take a turn on the implementation team and really focus on some of these policies and procedures and some of the training and some of the organization around the work, not the exact steps in the work. So that is the end of the, oops, hang on, sorry about that. Let me go back to my PowerPoint. Hold on. Uh-oh, I wiped out everything. Hang on, bear with me. Sorry, everybody. I closed the wrong thing.
No worries. This has all been gold. Thank you so much, Laura.
Okay. Are there any questions in the chat while I'm trying to figure this out?
None have come in the chat. But if anybody has any bit that they'd like to unmute and ask, that's totally fine.
Okay,
He said this has been so great and helpful. Thank you.
okay. Yeah, sorry, I have to go all the way back into my SharePoint and go into the documents and reopen it. Lesson learned about closing things out while you're in screen share.
I have a quick question.
Yeah.
For that last chart that you were showing, the desired for certain trainings and resources, it looked like from 2021 to 2020
Yeah.
that all of those had decreased. So do you
Yes.
think that that's in response to, over that year, the resources that you had been providing?
That's a fantastic question. And we actually talked about that quite a bit on the implementation team and sent implementation team members back out to talk about that on the team. And we think there's a couple of things happening at once. COVID and a switcheroo of priorities on a dime, because we are that federally qualified health center, remember? And a lot of people who were in the beginnings of focusing on training for zero suicide switched and got pulled into like a COVID response for probably 6 to 8 months and really took away from what we thought was happening related to zero suicide. So I think that was one piece. I think the other piece too that played into that at the same time was also turnover and staff starting at a time in which there was a gap in training. They started their job new and we were middle in the COVID response. So training didn't come for them for quite some time because we were caught up in other things. So that is kind of what we were thinking. I don't know if other folks think that makes sense.
Yeah, just curious, but I think that makes sense for sure.
Yeah. It's been really quite the fascinating, I'm sorry, let's start over here, journey with the surveys and figuring out what we have learned from the surveys, which is, if I get there, my next slide. Okay, so what does the survey even tell us? And what do we, again, we have more pictures of the zero suicide implementation team. I think one of the hard things for us is figuring out what is the survey telling us what we think it is, or and our staff understanding the survey when they're answering the questions, which is always kind of an unknown. Does it really give the report cards, that we think it does? We definitely think the communication element, when we scored low on staff not understanding what was going on with zero suicide, that to me was the direct report card of the communication that we thought we were doing, but was clearly not landing. So we changed some tactics related to that. We are trying to change some tactics related to policies and procedures. And unfortunately, a year later, we still have not made as much headway in that area as we would like. So I'm expecting to score again that staff want policies and procedures, which as one of the compliance officers at CCH makes me kind of laugh because people don't like policies and procedures, but apparently they want them for some things. I also want to make sure that we had to rethink. It was really like a duh moment for a couple of things. One was that employee role section. Strongly encourage you guys to look at that employee role thing and think about how that's going to come out for you and how you might need to think about that. We also need to think about for ourselves, we are highly infiltrated with behavioral health staff organization. We have a huge number of behavioral health staff in direct service roles and in management. So that kind of skews our results slightly a little bit anyway. Our behavioral health staff are more likely to even respond to the survey than any of our other staff. And as you saw by our results, we didn't even we have about maybe a fourth of staff responding, which is a decent number for survey results for people who do surveys, but it's not enough because I can tell you that 184 people is not even all of our behavioral health and supportive services staff. So one thing we did, which was like a duh moment for us last year, is that we left the survey open for the entire month of August. We did weekly like cries out for please respond to the survey organization wide. The third week of the month, we started like a Starbucks gift card like giveaway to get more people to respond to the survey. And by the end of the month, we'd gotten to 184. And we kind of called it a day at that. But in thinking about who is likely to respond to your survey is really interesting to me, because then that actually skews a little bit the survey results that you have. We definitely we had to rethink that question on the client death, and we're really happy to see that the Zero Suicide organization had changed that question to include like a time frame on that. So we're really interested in seeing that answer to that question. To that. And then one of the things that we had to do on the Zero Suicide implementation team is teach the implementation team how to read the survey results. We found that not all of the people on the implementation team really knew how to read a survey. And what is it telling us? What does it mean? I think we had 3 meetings in a row where we were like debating for an hour at a time about things in the survey until the implementation team came to some more consensus about what it meant. And of course, when we got the results, then once the implementation team felt like they really understood what the survey was saying, then we have that team champion those results, go back to all of their teams and communicate the results out wide. We also wanted to really empower the implementation team on, kind of what's next as related to the survey results. Now, I know we're kind of running out of time here, but I just want to make sure, and please, if anyone has any questions, get back in touch with me. I just do want to make sure to take that final moment again. Everyone should just breathe in for a second and take time to, look at the trees, look at the sky, whatever it is that you need to do. So thank you so much. And I'm happy, I'll put my email into the chat. I'm happy to answer, any more questions or answer questions if you want to email me later. And I would love to hear from other people that are, maybe probably more expert than I am about the survey, about how the survey's gone for them. I would love to hear about that.
Thank you so much, Laura. We did have one comment in the chat from Chuck, not necessarily a question, but might be curious to hear your thoughts. Noting that it was interesting that medical staff reported little training, but seemed to indicate confidence in screening for suicide risk. Perhaps they feel confident in their abilities and don't attend training because of that. So I think just kind of guessing at your results and why that might be.
Well, are there any doctors on this call before I answer that question? Just kidding. I'm just going to say it, even if a doctor is on this call. And I feel like often doctors feel like they are taught to feel confident in medical school. And many of them do have training, and they may feel competent in suicide risk. And they may well be competent in suicide risk. Our problem at CCH is that they're not doing the Columbia, they're doing something else. So we don't have like a fully, together Zero Suicide implementation. They're using the PHQ-9, they're using question 9, and then they are doing this thing that I'm just going to say really bluntly that I think what Zero Suicide is all about not doing is referring to the behavioral health staff when they get a complicated risk situation or risk screening. They very, very, very frequently refer to the behavioral health staff. And one of the things that we have talked about, and I think it's talked about in the academy, and it's talked about in Zero Suicide, and it's talked about in the research that shows that most people who kill themselves are seen in primary care, not in behavioral health. And I talk about that in my Zero Suicide training, and talk about we want this to move past the responsibility of only behavioral health staff. And I say that very directly and very bluntly, and yet we still continue to fall into that trap ourselves. I don't know if that totally answers the question, but that's kind of my feelings about it. Any other questions or anything else? Is anyone out there looking at the survey for the very first time and has to do it this summer? I can go offline and give you some advice. Has anyone else done the survey for a couple of years in a row and has any advice for me and our team?
So, hi, Laura. I'm Christina Dolan, and I represent Centura, and we have done the survey a couple of years. And really, what kind of helped us gain some traction is having the CEO of all of our individual hospitals send a personal email to the associates explaining to them a little bit about what zero suicide is, how we've implemented it at Centura, what we've done in the past year since the previous year's survey results. Like, you asked, we answered, kind of, like that thing. You guys asked for more training in this specifically, and we provided you that training. And that really just kind of engaged the associates. And then at the bottom, there was a link to complete like that current year survey. So that was really helpful for us.
Do you feel like your response rate is where you want it to be?
Well, we have over 21,000 associates, and my response rate last year, I think, was around 1,400. So no.
Wow, that's a lot. And do you have the same issue with kind of the role piece and kind of are more behavioral health staff responding to the survey than other people? Do you?
Actually, no. Interestingly enough, it's nurses that we have the highest response rate, and then we had a pretty high response rate from doctors as well. The behavioral health staff, I feel like, because we have done the survey so many years, they're kind of like, oh yeah, we've done that. We already know this, we've got it. There's some response, but it's actually fairly low from behavioral health. In subsequent years, when I first did the survey, it was mostly behavioral health staff that responded, but they've kind of fallen off a little bit.
Okay, interesting. Thank you so much. Maybe I believe someone else, it may have been you that has said that in previous monthly gatherings about having the CEO message related to the survey, and maybe, it opens on Monday. I might have put a day or two to go bother our CEO and see if he's willing to do that, see if that helps a little bit, because we would like our response rate to be a bit higher so we have more information to work with, and we'd like more people outside of the behavioral health kind of role to respond.
Yeah, well, and I do think, normally, I send people emails all the time, so they see my name and I think they just are like, oh, skip. So I just think, anytime you get an email from somebody kind of in a position of a little bit more power, it kind of piques interest a little bit.
Yeah. Okay. Thank you so much.
Thank you again, Laura. I don't see anything coming in the chat, and I actually have one question for you as well. Knowing that you've used this workforce survey as such an informative tool for your kind of ongoing implementation, I know that there's some folks on the call who are focusing on kind of branding or giving information about zero suicide to their new employees as part of onboarding. And I was just kind of curious if you could emphasize again how the workforce survey has contributed to how you do onboarding, and specific to zero suicide as well, like what that orientation looks like for people new to CCH.
Good question. And I had never even thought about that before, about actually doing the workforce survey during onboarding. So you get like kind of a true baseline, that's fascinating. So at CCH, we do have a couple of those HR team members that I just begged, and they work down the hall from me. So I just begged and begged and begged them to join the implementation team, is what happened. And once they got on, and one of the persons actually has personal experience with it, which is what you find on the implementation team, in my mind, is that people volunteer because they have a direct tie. They in the movement, or they have a direct tie with trauma and loss related to suicide. So we're lucky enough to have someone who is really engage in HR related to this. And we do in our onboarding, we give them this staff, this flyer about zero suicide, and we give them this badge, which has our risk ID. I don't know why I'm leaning forward. I just need to move my badge forward. It has our risk ID question on it with like crisis number on the back. And we give that out in the orientation with a quick, like really 5 to 10 minute blurb about what zero suicide is. So, I mean, on one hand, it's great that we have that at all. On the other hand, a 5 to 10 minute blurb on their first day when they're like learning everything else is probably not enough. And so it might be something that we looked at, to add on to that. And actually, honestly, using the workforce survey in some piece related to onboarding would be really fascinating and interesting to do.
Yeah, I was just curious, and thanks for your thoughts, just because not everybody has an employee onboarding specific to suicide prevention. And I know, given your work, that you've done that with zero suicide. So yeah, thank you for your thoughts. I appreciate it.
Yeah.
Awesome. Well, we are 2 minutes to the hour, so gonna wrap things up here today. I will be hanging around in this Zoom room again if you'd like to stick around if you have any specific questions or matters to discuss. I know Laura dropped her email into the chat as well. As per usual, I'll be following up with the slides and recording from today and a whole suite of resources and opportunities as they've crossed my inbox. But otherwise, thank you so much, Laura. That was wonderful. Super helpful.
Absolutely.
And
thanks, everybody. Take
yeah,
care.
thank you, everyone. Have a great rest of your day.